few other people. For some reason, all of our sessions have started out just like this, and probably about 15 minutes into it, there are people standing on the back wall. That may be the case, it may not be, but whatever the case, we're glad for the people who are here, and we're going to make sure that you leave here with information that's going to be of benefit to you. I'm going to speak very briefly just on behalf of the Congressional Black Caucus Foundation, the Emerging Leader Series, and bring up someone who made this event possible, who financially backed this and also supported this through logistical help and through helping to conceptualize the panel. And that's AstraZeneca. AstraZeneca is the corporate sponsor of Brain Drain. And ironically, the person who I worked with the most, his name was Michael Drain. And so so he shares the same last name as his panel. I know that's corny. But here to represent AstraZeneca today is Lisa Davis, who's the Vice President of Corporate Communications in the U.S. for AstraZeneca. And I want you all to give her a warm welcome, and she's going to tell you all a little bit more about herself and AstraZeneca's interest in this topic.
Thank you. The topic being discussed today is so important that I'm going to be very brief in my remarks. But I first want to thank our panelists for being here and taking part in what is a real serious issue, and being able to shed some light, and to the people in the audience for participating. On behalf of AstraZeneca, we have more than 12,000 employees in the United States, and we are very proud to support the Congressional Black Caucus Foundation in projects like this, as well as our support of the Black Health Empowerment Project, which many of you know is a community-based outreach effort really getting at African Americans in treatment with obesity through education, through eating properly, through tests, through exercise. And through that, in the CBCF's work, we are able to help those in populations of color deal with what is a growing issue in the world, but certainly more so for people of color. At AstraZeneca, we are one of the world's leading pharmaceutical companies, and most people may not know our name. They know a lot of the medicines we make, like Crestor or Nexium, Seroquel, and our long history in breast cancer, research and medicines like Arimidex. But the number one thing that we do is attempt to make a meaningful difference in people's lives and improving their health, not just once they get disease, but certainly in attacking and providing support for preventing chronic diseases like obesity. We're an R&D-based, research-based pharmaceutical company, and that is the heart and soul of what we do. But in addition to making medicines, we really challenge ourselves with another question: is it enough just to make the medicines? If people can't afford them, if people don't know about disease and how to prevent, even setting up a situation where you have to be on our medicines, we don't think that is enough for us to just stop right there. So we have an industry-leading prescription assistance program. So for those without insurance and who need our medicines, and a lot of our medicines are focused towards chronic disease, in addition to obviously cancers and terminal diseases like that, we actually work with communities, we work with people to get access to our medicines, as well as being able to provide education and support and partnership with the Black Caucus Foundation and other groups that will allow people to just improve their health overall, and that goes straight to the mission of AstraZeneca. So I want to thank you for this opportunity to come and participate. Thank you for the Black Caucus and allowing us to be a good partner and being a good partner, as well as providing forums like this around which people can get some of the information and engage with very knowledgeable, intelligent leaders in the healthcare industry around what we can do to combat disease and chronic disease, as well as understand what it is, this brain drain, in the healthcare industry and healthcare field. So thank you all very much, and I hope you enjoy the panel.
All right, thank you very much, Ms. Davis. Next, I have the honor to introduce and the privilege of handing over the podium to actually one of my best friends, Dr. Leon Caldwell. And he's not just on the panel because he's one of my best friends, but he's a highly qualified and competent individual, someone who I've known for probably about 10 years now. I met him when I was a master's student at Penn State. He was a doctoral student. And he built up a reputation at Penn State for advocating for the needs of African American males, particularly those in the inner city. At Penn State, he started a black male initiative, the summit. It was a summit for black men right after the Million Man March. And he attracted people from all over the region to Penn State to talk about issues related to black men. He has a PhD in counseling psychology from Penn State. He's held faculty positions at the University of Memphis and also University of Nebraska at Lincoln. He's currently the president of the think tank for African American Progress, who's having their national think tank or their international think tank in Memphis next week. He's the director of the Center for the Advancement of Youth Development and a fellow of the Urban Child Institute Research Associate Professor at the University of Memphis. He's done great work here and abroad. He started a program in Ghana where he took students from the University of Nebraska to Ghana once a year to work on health issues in that area. So it's my honor and privilege to introduce to you all Dr. Leon Caldwell.
Thank you, Ivory. You haven't aged a bit in those 10 years, by the way. I'm really excited about this panel, and mainly because this issue of brain drain is always a topic, and when you do international work, you can see some of the similarities. Particularly my work in Ghana, they confront the absence of service providers who come to the U.S. and they get their education here, and then they tend to find ways to stay. And you know, the country is in dire need of health professionals and other types of professionals. Well, similarly, many of us, I'm born and raised in West Philadelphia, we go and we get our degrees at various institutions, and how many of us actually go back to those places to provide services. So it's a similar dynamic. And one thing I was talking about this topic to one of my colleagues, and what was clear is in the U.S. we do have an advantage that there's several West Philadelphias around the country. So regardless of where you may have come from, you can find those spaces and places to do the work that's necessary for underserved and underrepresented groups. I don't want to get too much into our topic because we do have a very esteemed panel, and I just want to do brief introductions in the interest of time. I'm just going to give a name, and most of the information is in some of the reading materials for this panel. So I'm going to go in the order I have them presented, and I'm not quite sure they're in the order of seating, so you just kind of wave as I say your name. First is Ted Alamayu. He's the founder and executive chairman of U.S. Doctors for Africa. Then we have Dr. Paul G. Alexander. He's on his way. Okay. Well, when he gets here, we'll say hi to Paul. We have a Dr. Virginia Bishop, who's an assistant professor in preventive medicine at Northwestern Feinberg School of Medicine. Dr. Bishop. We have Dr. Linda Elam. I see. She's a senior policy associate with the Kaiser Commission on Medicaid and the Uninsured. And then we have Dr. Amadou Jackie Khabar. He's an assistant professor in the Graduate Department of Public and Healthcare Administration and a member of the Committee on Africana Studies at Seton Hall University. And finally, we have Dr. Terrence M. Fulham. So, I'd like each panelist to give brief remarks, and then emerging leaders time, that's 10 minutes. You'll see me wave my cell phone when you have 2 minutes. And I'm sure many of you have prepared statements, so let's start to my far right.
Good afternoon. First of all, I want to say thank you for allowing me the opportunity to be here. I'm sort of last-minute fill-in for Dr. Patricia Turner, who's Associate Professor of Surgery at University of Maryland. And unfortunately, you're going to miss out on a great treat. She's one of the top women's surgeons in the country, certainly one of the top African-American surgeons. But she had a commitment, had a conflict, and asked me last evening to fill in, and told me, of course, that I would fit in just great. So, of course, I immediately felt this anxiety. I had the opportunity to give the Alfred Goldson lecture just recently, earlier today, and so I was here. So since I was here, could I come by? And then, of course, then she sent me the information, and once she sent me the information, and I started looking at brain drain. The first thing that came to mind to me was really the Philippines and Nigeria, and how a lot of those doctors have come to the U.S. and because of that, there's a paucity of physicians, particularly in the Philippines, and so I was trying to figure out, what did I have to offer this panel and this area, and as I read a little bit more, I realized that my own story is exactly what we are talking about here. I'm originally a Pittsburgh native, went to Penn State undergrad, by the way, finished in '79, and came to Washington, D.C. to go to medical school at Howard University. Went from an area of 20% minority to an area of majority minority, and just fell in love with the area. And it was my passion and my goal to provide health care to the underserved in Washington, D.C. Finished my training, medical school at Howard, stayed at Howard for my surgical training, joined a private practice group in the area, worked at D.C. General, worked at Capitol Hill, worked at Greater Southeast, worked at all of the area community hospitals, stayed at Howard, became assistant and associate professor of surgery, got involved in minimally invasive surgery, brought that back to the area, felt very, very comfortable about the fact that there was one particular day where I performed a minimally invasive procedure on a homeless person at D.C. General in the morning, and then on a dignitary in the afternoon. And it was very interesting because the homeless person went home a day earlier than the dignitary did, but that's another story. So felt very, very happy about what I was providing the community. And then as the 80s became the 90s, and the 90s became 2000, the managed care area, the effects of managed care on the private practice became significant. I left the group, went out on my own, and tried to survive out on my own, but because of decreased reimbursements and increased overhead, my practice rates went up. I'm also a bariatric surgeon, so that's one of the higher malpractice issues in medicine, so began paying in excess of $100,000 a year for medical malpractice. When you develop a bariatric program, we have a saying that if you build it, they will come. And so I became a primary care physician, not just a tertiary care physician. If you know anything about weight loss surgery and management, you provide care for a long period of time. So my practice exploded. One of the nice things about it is that my income increased, but one of the not so nice things about it is that I had to expand and had to hire more staff, had to get additional offices. Because of the decreased reimbursements, because of the continued increase in malpractice insurance, my overhead expenses went from about 40% to about 78 to 80%. My taxable income, although my practice quadrupled as far as gross income, my taxable income, the amount of money going home to my family, did not change significantly, maybe $50,000, $60,000. What did change was the fact that I was busier, I was home less. I had three children, not homeless, but home less. I had three children who were growing up, a wife who was a physician who still didn't understand. And so therefore, it became very apparent to me that what I wanted to do and how I wanted to live my life, and of course, family first, God, family, and then your profession, was being challenged. And so I left private practice, got a full-time academic position at the University of Maryland, and then still provided service, but a different kind of service, more commercial insurance types of service. Fortunately for me, I was able to come back to Howard. I'm now back at Howard since March of this year, and plan to make a difference. But it was the economics that really drove me away from what my dream was, what my goal was as a physician in providing the kind of health care that I wanted to the community that was underserved. So I think I have maybe a little bit to provide as we go forward. But again, I just want to say thank you for having me, and it's great to be here.
Thank you. Hi, my name is Ted Alamayo, as has been introduced as the founder and president of U.S. Doctors for Africa. When my good friend, Dr. Avery Tolson, approached me to be a part of this panel, I was extremely ecstatic for two reasons. One, what really inspired me to form U.S. Doctors for Africa was specifically the brain drain that the continent of Africa is suffering from. And so this is a no-brainer for me to gladly accept and be a part of this. What I hope to talk about, by the way, I have no medical background at all. My background is finance. What inspired me to start this organization over 10 years ago, and what we have done during that 10 years period, both in terms of sending volunteer doctors and nurses to different parts of Africa, in addition to participating some of the needs right here in the United States, particularly during the Hurricane Katrina, Rita, and Francis back about 4.5 years ago. You can look us up and Google U.S. Doctors for Africa. You can learn quite a few things. What we're hoping, at least what I'm hoping to discuss at some point is, although the need for doctors throughout the continent of Africa is something that everybody's aware of, and the problem is growing, that continent becoming the mother of brain drain, both in terms of losing the extremely needed professionals, as well as other expertise leaving the continent for a better pay position or some political reason. It's an extremely complicated situation, but the solution could be, there should be a lot of remedies that we can entertain in terms of solving that problem, but it really comes back to engaging with the community, the medical community, the diaspora African doctors to go back and serve their continent. Now, having said all of that, what I'm excited about is to talk to you about what our plan, future plan, U.S. Doctors for Africa's plan domestically, which we're preparing to introduce the U.S. Doctors for Africa domestic response team that would work with the local authorities or cities in the states, when the time of disaster like Hurricane Katrina and Rita, and God forbid if we run into any other problem similar to that. So I'll stop here and we'll discuss more later.
Good afternoon. My name again is Amadou Jackie Khabar. It's sort of a homecoming here for me. I went to high school here in Washington, D.C. for 2 years at St. John's College High School, and I went there yesterday to visit. But I'm originally from Liberia, West Africa, and I have my own version of what you call the American dream story. I was literally found at a local YMCA in Monrovia, Liberia, when I was young, and I was brought to the U.S. by an African-American family. I went to school here, high school, and I was lucky to get a basketball scholarship. And I'm very, very grateful that my uncle and his wife are here today. These are the people responsible for me sitting in front of you right now. I really would like for them to stand up. Uncle Charles Neal Jr. and his wife Jewel Neal. They drove me to a lot of basketball practices. And I'm 6'11", if you want to know that. I'm 6'11". I play college basketball, high school basketball, so we have that behind us now. But for my presentation today, I wrote a paper entitled The Black Wall and the Dual Brain Drain, a focus on African Americans. When I played basketball, we had a lot of free time. We traveled, when I was in high school, we traveled to Las Vegas. In college, my first game I played in Hawaii. We traveled to Alaska. So we had a lot of free time to read and study because all we did was study, play basketball, travel. So what I did was I used to memorize a lot of statistics about NBA and college basketball. Then I found out that I injured my back my last year playing and realized I could not play professional basketball. So I cried about it for a while, and then I gave up crying and said, why don't you just go and get a PhD? So, and that's what I did. And at age 27, I got a PhD, and I turned all that energy I had memorizing basketball statistics to memorizing social science statistics. So most of the papers I write now, I write them because I study data late at night, studying US Census data, UN World Report data, World Bank data, and just looking for trends, similarities, contrasts. And then when something catches my attention, I say, why is this happening? What are the factors responsible? Then I go on and do the study. And that's what I was doing when I found out that there are certain similarities and differences and contradictions among people of African descent all over the world. So that's what this paper is going to focus on, discussing what I now see as the dual brain drain affecting the black world. Thank you very much.
Hi, my name is Virginia Bishop, and I presently work on bridging the cultural divide between academics and minority communities. As the co-director of the Northwestern University Community-Based Participatory Research Program, I am challenged with finding ways to engage communities in research and engage academics in community research that are both equitable and respected. As a preventive medicine educator, I am challenged with developing relationships with communities and community-based organizations so that I can place my MD, MPH, and freestanding MPH students into their sites for their field experiences. As a minority community physician, I am challenged with working with parents and community-based organizations and educators in youth agencies in terms of enhancing and optimizing my patients' health and educational opportunities. While we're looking under my hat of CBPR to conduct research to answer questions about public health and maybe quality of life, for example, communities are struggling to survive. We're looking at scientific rigor and we're looking at decreasing bias in investigational studies. Communities are looking for solutions to public health issues. While we look at what are the minority populations we need to study, minority communities are looking for resources and access to quality health care. On this journey to increasing the capacity of minority communities in partnering in research, framing and prioritization of health questions, deciding appropriate ways to ask questions and identifying what are the right questions, figuring out the appropriate methodology, then working on analysis, having them sit at the table, interpreting the data, then collaborating on disseminating of the data, and helping to determine the most culturally appropriate interventions, I have learned a few things that seem applicable to our brain drain. Number one, there are a limited number of community-based organizations and community representatives that are knowledgeable of how to navigate the health system, let alone how to negotiate equitable partnerships in research. For me, this translates into a need to learn about health systems, who to ask questions, how to ask questions, what to ask for, and where to go to get the necessary tools. Number two, there's a limited number of healthcare professionals that know how to work with community-based organizations or community representatives as partners. Healthcare professionals and researchers don't know who to ask in the community, how to ask the questions, what to ask for, and how to conduct collaborative research with communities. There is a great need to increase education and improve our present educational system. Although I'm speaking about research, this also parallels the issues of healthcare delivery, healthcare access, medical education, and having the critical number of culturally sensitive individuals in the healthcare field to broker these and other partnerships. So in terms of brain drain, in 2008, 2% of U.S. medical student graduates opted to go into primary care. Did you guys hear that? Only 2% of U.S. medical students opted to go into primary care. In 1990, it was 9%. So who's doing primary care in the United States? International medical students. They're the ones that are filling the primary care gap. Primary care is holding steady, but the U.S. population is growing and it is aging. In the Journal of the National Medical Association, underrepresented minorities make up about 6% of the physician workforce. In 2006, underrepresented minorities that are medical school graduates comprise 14% of the total graduates, while 30% of the United States population are underrepresented minorities. There's a little bit of a disproportion here. Once underrepresented minorities graduate and become physicians, they are more likely to provide care to minorities. Finances. Many underrepresented minority families don't even consider medicine as an option because of their limited resources, including that they can't fathom how they would be able to finance their child's education. An average medical graduate in 2007 owed $140,000. Schools like Harvard and University of Chicago are beginning to have more incentives, more increased need-based grants. They've eliminated family contribution for students in families that earn less than $120,000 annually. But students still annually may need to get loans of up to $24,000 per year. Pritzker tuition and related expenses average $60,000 annually. Even state medical institutions are costly and prohibitive. Despite these financial plans, there's still a limited number of underrepresented minorities. Why is that? There's a need to increase, obviously, the number of underrepresented minorities. There's actually a need to increase the number of underrepresented minorities applying. If you don't go back in education, we will always have the same problem. We can give a lot of money to medical schools and medical institutions, and obviously I'm a representative of a big name medical institution, but if we don't have enough people being educated in high schools, in colleges, and in elementary schools, we're going to continue to have the same dialogue 10 or 20 or 30 years from now. There's a need to improve reading, writing, math, science skills of students in elementary schools. In Chicago, with Reverend Meeks, recently we have become more aware of the fact that with increased finances going into certain schools, the quality of the education improves. One of the key outcomes is higher grades and standardized tests. Another soft outcome is increased self-esteem. Another one is improved communication skills. Isn't that interesting? Those are all the skills you need to have in order to be able to sit at the table when I'm interviewing you to get into the medical school. Isn't that interesting? We also need to increase the numbers of competent teachers, and also hopefully decrease the bias in overdiagnosing minorities as having special needs. Blacks represent 16% of the U.S. student population, but represent 32% of those that are diagnosed as either mildly mentally retarded or having serious emotional behavioral disturbances. This is a recipe for failure. Along with finances and maybe incentivizing quality education and increased access to underrepresented minorities in these programs, there's a need to increase the capacity of parents and communities to advocate for improved educational services and supplement existing educational systems, taking advantage of tutorial and other after-school enrichment programs. There's a need to bridge all underrepresented students in elementary school, high school, college, and medical school. These mentoring and tutoring programs allow students to consider medicine as an educational option, to be able to ask questions about the process, to plan the necessary steps for getting into strong academic high schools, colleges, and medical school. So thus far I have mentioned money, going into medical schools, going into colleges, going into high schools, going into elementary schools, after-school programs, tutoring and mentoring. There's also a need to incentivize the number of underrepresented minorities in colleges and medical schools. In 2006, the American Association of Medical College set a mandate that all medical schools increase their class size by 30% to address shortages in healthcare professionals. Why not increase it with competent underrepresented minorities? There's a need to mobilize underrepresented minority physicians and medical school academicians and research to spend time in underrepresented minority communities, not just as healthcare professionals, but as advocates in the school systems, joining PTAs, local school councils, and other community boards. This involvement and increased visibility can help motivate parents to dream for their children. The access to a community healthcare provider may lead to a better understanding of the process and of progress that may help to prepare students to become competitive applicants in medical school. So the analogies in the community-based participatory research program and in answering how to reverse this trend in continuing unacceptable low numbers of underrepresented minorities in medical training programs are clear to me. You have to increase capacity, increase advocacy, increase funding, increase incentives to improve the quality of educational programs, and increase the involvement of existing underrepresented minority healthcare professionals with community-based organizations and communities. As noted, not all of these resources translate into money. But all of these resources may translate into increasing the quality of underrepresented minorities in the healthcare workforce. Thank you.
Good afternoon. I'm Linda Elam, and I am a principal policy analyst with the Kaiser Family Foundation, which is basically a think tank. My background is a public health background, and my master's and doctoral work were both in health policy and management, and I'm very much going to approach this question from that perspective, a health policy lens on this, and looking at some of the bigger picture issues, not so much at the community level, but in policy and planning. I have a few points that I'll put out for your consideration, starting with this issue of brain drain. And while I appreciate a lot of the similarities that we're looking at for African diaspora health professionals and communities, there is a distinction in the domestic situation in that, what we're doing in this country to take care of our lack of providers is skimming the cream from other countries that don't have it to give. And I would argue that in this country, we are letting our cream go bad. We are not taking advantage of a big part of our population that can address these problems and address them effectively. So that's the lens I'm coming from. And I'll just say the first thing is that this is a national problem. While it affects the communities that we're talking about, it is a national problem. And it requires national solutions. We cannot expect these communities to fix this problem that is generations and generations in building, and that they just don't have the resources to address. The brain drain situation domestically is definitely a manifestation of our fragmented and uncoordinated way that our system runs. We have a lot of different centers of control that don't talk to each other, that worry about their own vested interests, and are not looking at the bigger public health or the bigger public good. So we're not producing enough healthcare providers, and Dr. Bishop I'm going to echo a lot of what she said, particularly in primary care. And there we're looking at also, along with the physicians, the nurse practitioners, the physician's assistants, nurse midwives, dentists, behavioral health folks, pharmacists, and even those we do produce are not properly distributed. So we have a problem on top of a problem there. We are going to have an increase in consumption of healthcare services. We know that. We see it coming. There's no mystery about that. And yet, especially for certain providers, we're seeing less and less production. So that we're on a collision course with disaster there, and we've got to address it. But I'd also say that knowing what we know now about the context in which the medical encounter or the healthcare encounter interfaces with health writ large, we are doing a disservice if we don't include that kind of information in the training of healthcare providers, particularly as they interface with low-income and needy communities. What I'm talking about there really are population-based approaches to health and social determinants of health, and including those sorts of things like income, education, those sorts of elements that we know, quite frankly, are bigger contributors to a person's health care profile than their medical care. Not to diminish the importance of medical care, but that if you're going to be a healer within this community, you need to understand the context in which you're working and what it means to create a healthy community. And medical care is a piece of that. And I'll say JAMA, the Journal American Medical Association, the 10th of this month, had a wonderful issue for people who are interested in this. And there's a lot of conversation there, and a couple of statistics jumped out at me. One was that among a group that had been interviewed for a survey, and it was actually that gave the primary care data, I think, less than half of all students thought that access to care was a major problem. Medical students were talking. And only 42% of those students, and this was an anonymous survey, so people could be very honest, responded that everyone is entitled to adequate health care. And I'd say that speaks volumes to who's being admitted to school and what kind of training they're receiving. I will, coming from my perspective, say that health workforce planning has a role in this. And it's not trying to do socialized medicine or take away autonomy of providers at all. But there is significant public subsidization of education, and we have a right to ask for those resources being used to create public good. Some people have argued that mandates would be useful, saying that people must serve in underserved communities in order to do a public service. That may or may not work so well with the U.S. kind of culture and the way we tend to approach things. But if we do move our interventions upstream and say, you know, we need to produce this many primary care providers, and we need to have them go to these areas and start it from a higher structural level rather than mandating an individual to do something, we'd probably have greater success.
2 minutes.
Okay. I won't go into as much detail, but I have a few other points. Diversity in health professions, I'm sure I don't have to sell people on that. It's very important for several reasons. A lot of them Dr. Bishop just said. But I'd also point out there's evidence that diversity improves the educational experience for all providers, including white providers. They are more competent culturally. They're more able to deal with diversity. There are lots of good reasons for diversity in health professions that affect all of us. The expense of education, as Dr. Bishop said, is a big issue. And family income is one of the main determinants of who goes to medical school. It determines where they go to undergraduate school. That determines whether or not they're accepted to medical school. So we have to look at greater assistance for lower income students, and I'd say regardless of race, to help diversify by income the people who are going into health professions. The pipeline, the drain in the pipeline, like Dr. Bishop said, is much earlier for underrepresented minorities than for international medical graduates, and it manifests differently. Also, someone who comes out of school with a great debt load is much more likely to be incentivized, and doctors and other professionals are subject to market forces just like everyone else, to get out and start working right away. They're less likely to pick a career path that would involve research or that would involve, or even going further in their training to subspecialty training because their debt load is so high. And I would say that that's a brain drain as well. If promising researchers, promising academicians who will mentor the next generation are not able to realize their dreams because of financial considerations, that's a problem. And then finally, just in summary, the retention drain. So if you get people going, how do you keep them there? You know, you've grown them up. How do you keep them somewhere where the conditions may not be the best, frankly? You know, we have a couple of things. One of them, though, again, is paying them. And people who serve underserved communities are often reimbursed largely through public programs. And so one strategy, and we can talk more later, is to make sure that those programs properly reimburse providers for the services that they are giving because they're such a big part of their income.
I will share with you that as a physician trained at Case Western Reserve and Columbia, I did feel at the time that I was part of a group of brothers and sisters who were really going into medicine because we wanted to make a difference. I think the conversation, unfortunately, is a little different now among young men and women in college. The issue is, how are we truly going to pay for a medical education? I will be the first to say that I am the benefactor of affirmative action. I don't see anything wrong with saying that, because I think a lot of my brothers and sisters who went through medical school, who went through grad school, did benefit from many of those programs. Absent those programs, what I find is really the issue is being able to pay for an education. And I do believe we need to advocate more for coverage for African Americans. But, in these days, you can't explicitly stipulate one population. But if the issue is around inability to pay because of lack of family funds or economics, then I do think we should advocate for some increased coverage for undergraduate and graduate medical education training program. The other thing that I see as an issue, I sit on a scholarship review committee at Penn, and what's most interesting is there are brothers and sisters who are getting into medical school. But every school is reviewing the same number of African Americans. So you will find it's a very small population. They're being sought after by all of the best medical schools. The problem then becomes, if you have a population of students who are getting these very high-end scholarships where they're getting a tremendous amount of their education paid for, when you begin to look at what they've done, these were individuals who more than likely went to an undergraduate school, did well, but took a year or so off to really begin to explore why they wanted to go into medicine. So, they volunteered at health clinics, or they created a prevention awareness program around a particular disease state. But they've demonstrated an interest above and beyond just academic performance. I think that is truly an opportunity for any individuals who are interested in exploring medicine. Take time off to really figure out what you can do to demonstrate why you should be in medical school. Once in medical school, again, you have to compete just like everyone else, but in terms of the individuals who are being brought on board compared to majority candidates, they've really demonstrated this little extra something. Once you've graduated from medical school, gone to residency, the other strategy, the other issue is around being paid for the services you provide. I've had the fortune of being a chief medical officer for a provider-sponsored health plan, and that's a health plan that's owned by academic health centers. And we primarily manage Medicare and Medicaid patients. The reimbursement is very, very difficult, I think, for physicians who have large overhead, who oftentimes are not having patients who just come in for an every now and then wellness check. They have patients who have chronic diseases and therefore require an extra level of care, who may also require increased utilization of services. The system that we have at present does not pay for those services. They don't pay for the amount of time and effort and mental requirements for a physician to deal with a patient with more than 1, 2, or 3 comorbid conditions. So my second strategy is definitely increasing the reimbursement for patients who are in quote-unquote Medicaid and Medicare programs. And I know that CMS has that accountability. They are beginning to look at what they call a little bit more cultural competent care, which you have groups here in the Washington, D.C. area, for instance, like the National Medical Association, that are working on elevating the awareness of what it takes to manage a patient from the inner city or a patient from the rural environment who have more than one comorbid conditions, who aren't necessarily attached to a medical provider or a medical system. So we do need to advocate for increased reimbursement for physicians. So now my third issue is people say to me, you're out talking about the brain drain, but you're a physician who now works for a pharmaceutical company. I didn't share with you that I actually work for AstraZeneca. and I'm an executive director of clinical relations. I've now been on faculty at Penn as an academic physician. I see patients through a free clinic. I've been a chief medical officer for a health plan. But what's really interesting, coming into an industry where I see the changing dynamic in the development of drugs, and bear with me if you will, because this doesn't initially sit well with African Americans when I talk about some involvement in clinical programs. But, you know, as a physician and as an African American, I was able to go into this very large organization and say, what are we doing trying to make medications or innovative medications to treat African American and Hispanic patients that actually work? You know, I love to ask this question of panels, you know, how many of you have ever been in a clinical trial? And very few hands go up. But if you ask how many people are actually taking medication, usually a sizable number of people put up their hand. The reality is, for that latter population, a number of them are actually in clinical trials and they don't know it, because there's no way to know that the medication's actually going to work. So I do think there's yet an opportunity for physicians, African American physicians, to get engaged in some of this drug development opportunities that exist and work for a pharmaceutical company. And that's why I made the decision to work for a large pharma company. Even though I'm in this industry, it's still important for me to reach back through free clinics, which I do. I run a men's health clinic in Philadelphia, talking to brothers and sisters who usually have questions around why I can't understand what the doctor's telling me and why am I taking this medication. So what I see is really an ever more important need for African American physicians to have access to their communities. Because you do find in our patients and our family members, many of you will have family members who go to the doctor, maybe a majority doctor, and I'm going to say they're probably well-intended, because I don't think anyone wants to not treat patients well, but not able to connect. And I think the value of having people who look like the patients that are being treated is tremendous. So my advocacy is around trying to keep young men and women interested in medicine. I do believe that for us, it starts before you get to high school. You know, we have particularly young men. It's gotten almost sublime that when you look at medical school applications, African American men are down below 20%, and very few actually go on to actually matriculate. The challenge is trying to get young men and women exposed to leaders in our community who are African American, who are physicians, who can set examples. There are a number of programs out there. I know the AMA has put a program in place as they try to increase their outreach to African American physicians. I know you have groups like the 100 Black Men that are doing so also. So we are trying. I just don't think we figured out the answer. At the end of the day, the primary issue for me is economics. People choose not to go into medicine because they see it as being very expensive and they don't think they're going to get their money back. So we need to advocate for some form of subsidy based on economic need. And once you're there, try to figure out in your practice setting how you can begin to bolster your income. It is a very challenging paradigm. I mean, I don't sit here with any answers for you. If anything, I probably have more questions, like all of you. But I'm optimistic that, you know, we can continue through messaging like this and through conversations begin to make a change in our community.
Thanks, Dr. Alexander. I know you have to. You're off to another event, so. And this is the part where we get into some dialoguing or questioning. Each of you said some portions of your comments had to do with economics, the cost of medical school. And another, I think, consistent theme was where do we start in the educational practice. The question I have for the panel is, if we're going to narrow the gap, at what point do we start, and at what place do we start in terms of solutions? Do we narrow it with providing more educational access early, or access, as Dr. Alexander was saying, access to practitioners earlier in the process? Or do we start with, once someone's been tracked, and making sure that they have a trust, if you will. So when they get to medical school, the cost is not an issue. Yes.
Again, I think you can't use just one strategy. You need these strategies to work together. And one of the strategies would be to help expose young people, definitely before high school, to the wide range of health professions that are out there as well, so that they have an idea of many ways that they can serve the community as a health provider, and actually, what's realistic for them in terms of their financial and time commitments, their personal lives, what it is that they intend to do in terms of their families and so forth. And they can still have, there are a wide range of roles that they can take as a health provider. But they need the exposure, they need the financial support, they need all those pieces at the same time.
Okay.
I think that if you're starting here at point A, we have students right now that are presently in college, presently in high school, presently in elementary school. And so I agree there needs to be a multifaceted, multidisciplinary approach to dealing with this problem. And some of the solutions are using human capital, literally having people go out and trying to stimulate interest and thought and trying to get different organizations, think outside the box as to how we might finance improvement in education and improvement in exposure to the healthcare fields. I know that with most healthcare fields, the students have to do some type of clinical experience, be it field work, etc. Why not place the students into places that actually need more help? It is much more cost effective in some community agencies to have medical assistant students being supervised by the nurse or by a medical assistant that already has a job to get them stimulated and give them the skills to put them in a better position. The same with medical students, etc. The same with residents, the same with a number of different people. I think simply saying that we need more financing, we need to seriously look at where the money's going to and how much bang we're getting for our buck.
Right.
If not, we're just going to throw a lot of money into different programs and not really see the effectiveness or the utility of any one in particular.
Right.
Do you think I can quickly just summarize my paper? When you had said quickly, briefly introduce yourself, so that's what I did. But I could just quickly summarize my paper, and then I'm sure that will help to the discussion. As I noted earlier, the black world and the dual brain drain, a focus on African Americans. What I found out is that there are similarities and differences between black people all over the world. As of July this year, there are now 773 million people in Africa. Africa's total population by next summer, if not next summer, certainly after next summer, it will be 1 billion people. Well, what I found out is that Africa is experiencing a dual brain drain. African Americans are experiencing a dual set of the dual brain drain, 2 sets. And then in the Caribbean, in the case of Haiti, they are also experiencing a brain drain. For Africa, the first part of it, that's what we discussed. People like me coming here, getting the PhD, it would be very good for me to be teaching right now at the University of Liberia. And that would be so helpful. I know I get a lot of students that I help here, but it would be very nice. But I'm not there. So that's a brain drain. The second form of and I have the numbers here, by the way, in terms of those of us who are not home. According to a World Bank study and that was conducted in 2005, the study provided a table showing developing countries that are losing their talented people. And of that group, 7 of them were either black African countries, or in the instance of Haiti, a black majority country that is not in Africa. That shows the similarity that we have. Then I realized that we're experiencing what I call a terminal brain drain, and that is HIV/AIDS is killing people in Africa, where more people can read and write, have more high school, college diploma, and they have relatively strong economy. And for example, Kenya, South Africa, Botswana, Zimbabwe, even Nigeria, even though Nigeria has 140 million people and 3.5 million as of 2003 living with AIDS, which is quite high. And the prevalence rate was about 4 to 5%. So you say, oh, it's not as high as South Africa, but when you're talking about 140 million people, that's quite high in the actual number. So that's the second form of the brain drain in terms of that is affecting Africa. Now, for Haiti, Haiti's having the same problem as well. I have data here, I will send you to the paper, where Haiti is experiencing the most severe form of HIV/AIDS in the Caribbean, which is very similar to Africa. But in this study here, Haiti led the list in terms of those countries that have their most educated people who are not in their countries. Haiti, 84% of educated Haitians were not in Haiti in the year 2000. So think about that. Only 16% of educated Haitians were in Haiti. And I saw something similar here with African Americans. In 2000, in Newark, New Jersey, we're almost surrounded by Newark, where I teach at Seton Hall, and only 9% of the people in Newark, which now has over 270,000 people, only 9% of them aged 25 and over had at least bachelor's degree. In the town where I teach, it's 57%. And Camden, New Jersey, many of you know Camden, New Jersey, it is 5%. Now think about it. How can you have 5% of the total population of a city, majority black city, only have, that's very, very serious. It's very, very serious. Now, in the case of what I found in terms of African Americans dual set of the brain drain, the first one is international, the second one is domestic. The international one, after September 11, a lot of Americans, including African Americans, are genuinely going out there trying to help people. And I give Oprah Winfrey as one perfect example in terms of people who are going to help other people. And in her case, she went to South Africa, opened a school there. She could have opened that school right here in D.C. or in Newark, or in, right? But she went and did it because of the giving nature of African Americans. So African Americans have a lot of responsibilities. That's what I'm trying to say. You have a responsibility here, responsibility to people internationally. That's one set of it. But then two, I also try to conceptualize this brain drain by saying maybe we're also having a brain drain by sending people to fight in this foreign conflict. Mm-hmm. For example, it takes $9,000 to educate one public school student in the United States. So now imagine educating them only to send them to war and then they die in war. So you waste all that talent, all that money we spend on them. So that's another brain drain. Domestic brain drain. We just mentioned that in our cities, many times in Newark or Washington, D.C., we come from poor families. They spend all their money to help us. By the time we make it, we move out of the neighborhoods where we grew up and go to the suburbs. But when we go to the suburbs, that's where we pay taxes. That's where we fix our cars. That's where we shop. That's where we help to mentor the young people. So we are draining all the resources out of the cities that brought us up. That is a brain drain. That's another form of the brain drain. HIV/AIDS is the final one also in terms of the domestic brain drain. African Americans are being impacted now by HIV/AIDS, and not to the point like Africans in Africa, but it's beginning to get very, very serious. As of 2003, for every 1,000 of their population, there were 33 HIV/AIDS deaths for black males, 12.8 HIV/AIDS for black females, 0.4 for white females, under 5 for white males. So that begins to show you. And when I go and talk to basketball players, trying to advise them, I tell them, I say, when you're trying to date a girl, she tells you to go and have a test, you should be very happy to go have that test. Don't get angry at all. I tell her, I say, this is very, very serious. You would die if you don't have that, if you're not careful these days. And in fact, I'm now doing a paper where I've now suspected that the sex rate, the total fertility rate, the average woman is said to need to have 2.1 children to continue to sustain your population. From 1980 to 2004, the numbers are now dropping for African Americans. In 1990, in fact, it was 2.5 children, almost 2.6 children born to an average African American woman. As of 2004, it's 2.003. For the white, it's now even higher for the white. It is 2.055 for the white. So I'm now investigating what are the factors in contributing to this. In fact, I now have the HIV/AIDS problem as part of the reason why, because I have instances where some friends I know may get angry if the woman they are courting is telling them to go get tested. They take it, they have so much ego. So as a result, maybe that would be one way where African American women are just cutting down on sex altogether. So these are some of the issues that I presented in this paper and in many of my publications that I'll be sharing with you.
All right.